Henry and I are at the kitchen table, eating breakfast. Grape nuts, sliced banana, milk for him, oatmeal for me, with walnuts chopped small, fresh blueberries and dried cranberries. Mugs of coffee. I did not always drink coffee. My feeling was that it never tasted as good as it smelled, but with enough half and half, I like it now. Funny about how we describe ourselves. One minute we're, oh, I'm not a coffee drinker, never touch it. The next, we're solidly in another camp, have to have coffee every morning. Who we are can flip like that, the details always shifting. Henry picks up the sports section, folds it in half, then half again, pushes the rest of the Charlotte Observer to the far side of the table. I've got the living section. It's mid-February 2006. Outside, wintry and windy, and wet. "Doesn't this sound like a good idea?" he says, pointing to an ad I can't read from where I'm sitting. A non-surgical procedure for back pain, done by a physiatrist. "What's a physiatrist?" I ask, scooting my chair closer so that I can read even the fine print. "Well, according to the ad, physiatrists are MDs," he says. "Apparently they treat spinal problems." 6 years ago, Henry had surgery for spinal stenosis, which helped some, but his back has never really stopped hurting. He's stiff when he gets out of bed in the morning, can't stand for long, finds a chair pretty quickly wherever he happens to be. He lives a normal life, though, a normal life with backaches. He's so athletic, what he'd really like is to be able to jog again, play racquetball, tennis. Yes, I say, that does sound like a good idea. The physiatrist tells Henry he believes he can help. From what I can understand, he'll use fluoroscopy for guidance while he injects steroids and an anesthetic into the epidural space between the spine and the spinal cord. The procedure will take about 30 minutes, followed by maybe 45 minutes of recovery time. Henry will be monitored for an additional 15 to 20 minutes, then discharged to go home. An hour and a half total. Compare this to hours on an operating table, days in the hospital, the long recuperation that back surgery entails. This injection is so common, it's given to women during childbirth. The physiatrist explains that an epidural steroid injection can be highly effective because it delivers pain relief directly to the source of the problem. He recommends 2 injections, spaced 3 weeks apart. He needs to inject 2 different areas. As with all invasive procedures, there are risks. Generally, though, the risks are few and tend to be rare: headache, infection, bleeding, nerve damage. Henry signs the consent form. A week later, we report to the hospital outpatient clinic for the first epidural. Afterward, Henry's right leg is numb, very little feeling. The physiatrist, a tall fellow with a friendly face and thick, hay-colored hair anyone would envy, says something like, "The numbness is a great sign. It means the epidural is working." Henry's leg is so numb he can barely walk. He leans on me as I help him from the car into our house and to our bed. He goes right to sleep, which is unusual for him. I don't think I've ever seen him take a nap. The little bit of walking he did completely exhausted him. I keep checking the handout. If numbness persists longer than 8 hours, call the office. Every hour, I wake Henry to ask about the numbness. Every hour, he says his leg is still numb. Then he drifts back off. I don't relax my shoulders for a minute. The 8th hour, I have my hand on the phone, ready to dial. I ask him one last time. All feeling has returned. No need to call. My shoulders relax. His second epidural is scheduled for 3 weeks from now.